Welcome and happy Monday, Behind the Numbers listeners. We have Danial Qureshi on this week to chat about a set of research that we have not heard yet. Danial Qureshi is a research coordinator at Bruyere Hospital in Ottawa and has been throwing out those publications left and right since his master's degree. He chats about how he got into epidemiology, what kind of research you can do with big data, and all about his interest in palliative care and disparities in end-of-life care between populations. Enjoy. Welcome, Danial Qureshi. I'm honestly super excited to have you because I think you're going to give a really cool perspective and a new perspective on the world of research and realm of it. I know when I was kind of going into it, I thought you could only go into research if you're a prof or you had to be a doctor to get into research. So I think your experience, and I'm excited to talk about you as like a research coordinator, like you're throwing out the publications. Yeah. So if you could just start with like kind of how you got into research, how you started liking it or figured that was where you want to go.
First of all, thanks for having me on your podcast. I really
Thanks for coming.
it. Yeah, for sure. And I think it's a really great initiative, first of all, because it allows people to see how broad of a scope epidemiology and biostatistics really brings. So it's really going to show that, because right now you have all these clinicians coming on, but also people like me who are I'm not a clinician, and I'm kind of I'm new to the area of research, so it really shows people that broad scope.
Thank you. Yeah, that's what we're hoping for, to show that epi's not as niche as maybe people think.
Yeah, and just the word
more than just.
Yeah, just the word epidemiology kind of it already narrows things down. But like epidemiology is more than just that word, right? It's so many different things, right? It's like health services research, population health, it's health economics. There's so much.
What a plug into our first episode with Mary, where she talks about everything epidemiology. Way to tie it in. I love it.
But yeah, so I guess you wanted a brief background about myself and how I got into research.
Yeah.
I guess I could really start with from undergrad, really. So I did my undergraduate degree in life sciences at McMaster. And during that time, it was basically like a general science degree, but I had the opportunity to take a lot of courses outside of that area. So there's a lot of leniency in that sense. So I took a lot of courses in psychology, in health and aging, in religion, and it really allowed me to develop an interdisciplinary lens when it comes to just learning. And so when you approach scientific problems, I have this unique perspective where I can draw upon things from like psychology, social science, whatever, right? To really learn about a topic. And so my first research experience was working with a neurologist, and I helped him with like a case report on a movement disorder. So he particularly looked at, he does research on movement disorders, so like Parkinson's,
ALS. Awesome.
Yeah. So I helped him with the case report. I helped him with a review looking at some of the pharmacological therapies for Parkinson's disease. And also I helped him I made like a video series on Parkinson's disease education. So that was really like my first exposure to research. It really like helped me understand, okay, this is what research is about. This is the research process. And
was this early in undergrad or later on?
It's like in my third or fourth year.
Okay.
Yeah. So at the time, like I was just doing it to like just get a new experience. Like I didn't really, I wasn't like, oh my god, I wasn't like, oh my god, I'm so interested in this. Like this is exactly what I'm going to do for the rest of my life. Yeah. So I had that, and then like I also did a clinical practicum with a clinical psychologist, where we worked with acquired brain injury patients to help them learn social and communication skills. So we applied this intervention. It's called ABA, or Applied Behavioral Analysis. So I really drawed upon I took a lot of like psychology courses in my life sciences program.
Yeah.
But they would like help me draw upon that to like apply it to like a real world setting, and that was like really rewarding. So that was another
people who like had a major brain injury and had to relearn, or what was?
Yeah, exactly. It was like basically like ABA requires you to kind of break like any sort of task that you want to do. For example, like for us, it was like operating a Kindle, like an e-reader, right? A Kindle reader. And so we had to like break down every single step for him to like access one particular book, for example.
Oh, wow.
And so, yeah, so it's like a very like, things that you might find simple, like it's not, as simple for them because they have a brain injury. And it was a very repetitive process, but like it was just so rewarding at the end to kind of to see the progress that this patient made and to really have an impact on that patient.
For
Um,
sure.
yeah, so that was another research experience that I had. And again, like even at this point, I was just like, I don't know if I want to do research like for the rest of my life. It was just like, okay, I had these experiences, I'm interested in it, but I don't like, I'm not like, oh, I'm passionate about it. Like I
Yeah.
wasn't like that, I didn't have that feeling. And then so that was undergrad, and then after my undergrad, I went into my master's program, and that was also a master in clinical epidemiology. Um, and the reason for choosing that program, I had no particular reason. It was literally like one of my friends, he's a few years older than me, and he was in the program. He had like the same, like similar trajectory as me. He did a life sciences program, and then he went into clinical epi. Um, and so like he was kind of maybe biased towards the program, but like he was giving me advice, and I was like, hey man, like I don't know what to do. Like, and he's like, dude, just try the program. It's like 1 or 2 years. Just see how you like it. Like what else are you gonna do?
Yeah,
I was
yeah.
like, okay, all right, we'll try it out. And
That's so funny.
yeah, so like I was like, okay, we'll try it out. And I feel like to be honest, like I feel like a lot of students are in that situation where they're like you're not sure, so you just like do something.
Yep.
You do a degree that maybe someone else has done, and like one of your friends has done. And some of these people, like I looked up to that guy, right? So like
Yep.
I followed his advice, and like he really convinced me about the program. But yeah, anyways, I started my master's, and like right after I got accepted, I was like, okay, I'm in, and now you gotta like contact a supervisor, right, to like work with.
Yeah.
So like, okay, I contacted like 3 or 4 people. I had an interest in like gerontology and geriatrics because
Okay, I was
I
curious
volunteered.
if you knew what you'd even want to do research in, because you're
Yeah,
saying at this point you have no idea.
I had like I didn't know like research was it, but like I had an
Yeah.
interest in like gerontology and geriatrics because like I taught a course like I was a TA for like a health and aging course in undergrad, and so yeah, so I knew I had an interest in that area, and also like volunteered at a long-term care home for like several years, and I found it like super interesting. And so I contacted people in that area, and one of them was Dr. Xian Xiao. Um, he's a palliative care researcher at McMaster, and I remember I just like sent him a cold email. I'm like, hey, like I read your paper on this, and that, and I would like love to talk with you and like work with you possibly. And then he messaged me. He's like, sure, like if you want to work with administrative data, let's talk. And like in my head, I was like, what the heck is administrative
Yeah.
data? That sounds so boring. It's like, I was like, I don't know.
Is
But
that like
anyways, that night,
clerical work? Yeah.
yeah, exactly. Like I was like, what the heck is like administrative data? It's like, it just sounded so boring, to be honest. I was
Mhm.
like, what is this? Um, but yeah, like, he's a really great guy. Like he showed that he's like really passionate about palliative care, and like we seemed to get along in that first meeting. So I decided to pursue a master's with him, and um, but yeah, like I started working with the data at ICES, as a lot of us here in Ottawa do.
Mhm.
But this was at McMaster, and so I got a chance to work with some of the administrative data, those data sets,
Yeah.
and my impression of like that term entirely changed when I started my thesis work, and like I got to actually, at the time, you actually had to like go into the research hub. You couldn't work remotely, so like
Okay.
any analysis you had to do, you actually like go in, sign in, like it's like highly like secured area. Makes you feel like quite special. So you go in, and then I remember I sat down on a computer, and I got to see my first data set, and I was just like blown away. I was like, holy crap, like this is insane. The amount of like detail that you have on one patient is just nuts. Like I didn't know like you could do research like this, and I didn't know this is how research was done. Like
Mhm.
I think of like those like those researchers in psychology who do like those crazy experiments and all that. That's what research was to me in
Well, yeah,
my
that's why I'm so interested in this, because I'm more like clinical research. So I'm thinking more of like, how can I make an RCT, or like what actual
yeah.
trial, or like a lit review. I would have no idea what you give me a data set, like what that even entails.
Yeah, and no, that's absolutely right. And that's what I thought. Research is doing clinical trials, but no, like you can use administrative data for research purposes. Sometimes, most of the time, administrative administrative is not like purposely made for research. It's data that's already there that's collected, and so we just use it for research purposes. So you have to understand there's a lot of limitations too, right,
Mhm.
in terms of the data. But like when I saw that data set, I was just blown away because I'm like, wow, like there's so much data. So I was like, you have like a IKN, like basically identifies the patient, not their, it's confidential, but like you don't have their health card number, you have like a code particularly for a patient. And so you have like things like their age, their sex. For my project, it was like looking at palliative care. So I had the exact date that they received palliative care, the exact date they were diagnosed with a particular condition, the exact date that they got a specific intervention in the hospital. Like the list goes on. And it was just like,
Wow.
wow, like this is just one patient. And like the studies that I was part of involved like more than 200,000 patients. And so like you can go back in time and basically kind of understand their healthcare experience and like control for all these different factors, right? And
Hmm.
so I found that particularly fascinating. And like sometimes I would just like spend hours like in there and just like going
And
through
you're
the
getting like
data.
really accurate data too.
Yeah, yeah. And it's like I just couldn't believe that, I first of all I had a chance like as a master's student to make an impact that way with like real data and I really saw my impact, after publishing a few papers and like people were actually like paying attention to this work and finding it very useful. So that personally felt like very rewarding and kind of motivated me to like go further and continue this work.
So two questions before we move on to what happened next. One, where does this data, like how do they get this data? Is it data that's sort of taken from the hospital? Like how does ICES sort of get all this? Do you even know
Okay,
that?
so a little bit, yeah, I should. Yeah, so like ICS is very unique because they house a lot of these data sets, and they have a lot of data agreements with different stakeholders and organizations, and so they're very unique because like Ontario, like we're very, very lucky in that sense because in Ontario, all these data sets are housed in one location, and that's
Mhm.
ICES. Whereas if you go to a different province, they might not have such a system. They might to a certain extent, but not to the rich and comprehensive level that we have here in Ontario. Um, so in terms of like where these data sets come, like they come from a variety of sources. And so for example, like we have things like the discharge abstract database, or the DAD as they call it, um, where that houses all information related to like hospitalization records. So like things that I just mentioned, like intervention codes,
Mhm.
whether palliative care was provided in the hospital setting, and these are all based on code. So like as a patient enters, like they're in a certain bed, and so like any sort of care provided to them is recorded by people who are taking care of them, uh, and so we have access to all of that data. So
Wow.
it's kind of like a history of the patient, right, from an administrative point. And then other things like OHIP codes, like the Ontario Health Insurance Plan. So OHIP codes, so like that captures things like physician claims data. So for physicians to, so when a physician provides you a service, like let's say you go to a family doctor or something, or any sort of physician, they provide you a service, they bill for that with a specific code, right? That has like a
Mm,
certain fee associated with it. And
got it.
so, for example, like if I wanted to look at, like well, for one of our studies, we looked at like a life support intervention called ECMO um, in the hospital setting. So like there's an intervention code within the discharge abstract database to capture that, but there's also a OHIP code associated with that. So
Hmm.
to make our cohort, we combine both those data sets. And because and I didn't have that knowledge, like the clinicians have that knowledge, right? Because they are the ones actually
Yeah.
building these things. So and I had the responsibility of actually like compiling all those codes together to kind of create our cohort. So it's really amazing like what you can do with this data, and like it's just going to get better and better over time.
Yeah, especially with access to that many people and to that much information on them. And then
Yeah.
so going to your math, like what did you do as your thesis with that?
So my master's thesis, like I said, it was related to palliative care research, and so in my master's, I really kind of so my master was like it was I got 3 different publications out of my master's, but all of them were in the same area of like palliative care, and
Hmm.
so the first paper that I had was looking at the healthcare experience at the end of life. So, where do people receive care in their last 2 weeks of life, and how does that differ by disease trajectory. So does it matter if you're a cancer patient versus, someone who has organ failure versus someone who has frailty, in terms of these set disease trajectories based on the literature? So and we found that patients who have a non-cancer related illness usually end up using a lot of those, a lot more acute care services at the end of life, a lot more emergency department services at the end of life compared to cancer patients.
Mm-hmm.
And we also found that in general, among all patients, there's a huge increase in use of hospital-based services at the end of life, which could potentially be, avoidable. They could be avoided, right? With proper palliative care. So that's what we were kind of trying to get at. So that was the first paper. The second paper was kind of was building on that by specifically looking at palliative care. So I wanted to see how palliative care timing, how is that associated with services you use later on at the end of your life? And what we found is that palliative care that's initiated early on is associated with a reduction in the amount of hospital-based services you use in the last 2 weeks of your life. And again, there was differences between cancer and non-cancer related patients who have a cancer or a non-cancer related illness. Basically showing that non-cancer related people who have like organ failure or frailty, they end up using more of those services, but they also end up initiating palliative care a lot later on in terms of their end of life trajectory. So that was the second paper. And then the third paper, again, building on it, was looking at access to palliative care in a patient's terminal hospitalization. So that last hospitalization they have before they die. What does that experience look like? Do they have access to palliative care? And we're trying to highlight that a lot of these patients don't get access to palliative care when they could have, especially if they're already identified, to be on that end of life trajectory. And so we showed that I think 1/3 of all those who died in hospital didn't get palliative care, and those who had non-cancer related illness, a lot less got palliative care among those who did.
Wow. So moral of the story, we gotta take some better care of our elderly and get them into those long-term care homes earlier, because that will sort of diminish their frequency to hospital. Yes.
Yes. And like it's more about like having conversations earlier about palliative care. And palliative care has it comes with when people think of palliative care, they think of oh, like you're dying. Like no, it's not just for people who are dying. It's for people who it's a different approach to care. Right? It's not like, oh, you get palliative care, it means you're dying. No, it's just to deal with a terminal illness, and it's this particular approach. I don't know about what that exactly entails. I'm not a doctor, but a doctor can tell you a lot better. But it's definitely not for those who are just dying, and so people have the tendency to associate it with death. And so that's one of the major issues.
That's actually a really great point. I think it's death is such a scary topic that I feel like a lot of people are almost scared to talk about it or scared to plan for it, which seems to make the end of life process a lot more, not necessarily painful physically, but maybe even just mentally, constantly going to the hospital, constantly just not being comfortable. Maybe.
Yeah. No, for sure. It's a very difficult conversation to have. And, I've talked to so many clinicians who say the exact same thing. Even for them, it's they're experts in the area, but it's still difficult for them too, of course.
Yeah.
And I think part of this research kind of shows that having these conversations early on really helps families prepare for what's to come in the future, right?
And then how did you get from that to now you work in Ottawa? So where was that?
Yeah.
McMaster to Ottawa.
I was Hamilton sucks. Let's go to Ottawa.
Have they converted you to Sens fan yet?
No. Sadly, I don't really watch. I watch basketball. So
okay.
Ottawa doesn't have a basketball team.
Raptors.
So, hell yeah.
Okay. I'll agree with you on that.
Yeah, how I got to Ottawa. So during my master's, I worked with Peter Tennessee, who was a co-author on all my papers, and He was like basically an external committee member, like unofficially. And so that's when I got a chance to like work with him. So we had some previous contact, and he offered me a job like right after I finished my master's, and I got a chance to like meet his team and stuff. And I wasn't sure because I was like, okay, first of all, it's Ottawa, it's so far away, and like I don't know, like I want to work in Toronto. But like he basically gave me an offer I couldn't refuse, and like this team would just like I feel like I just like really vibed with the team,
Yeah.
and so I was like, you know what, like let's do it. It'll be like 1 year, whatever, let's do it. And now I'm here for like 2 years and going on my third year.
Yeah.
So I guess it really worked, right? He's very good at convincing people.
Yeah. And you're sort of
So
working
yeah,
on the same-ish field? Still palliative care, still.
yeah. So so like in terms of like the research that we're doing now. So first of all, I'm working as a research coordinator with Peter Tanisputro's team. He's basically like built a program of research that focuses on health services research and aging. So it's not just like palliative care, but it's just like bread and butter health services research,
Mm-hmm.
aging research, and then also trying to take things a step further by like developing things like tools to like patient facing tools or tools for like clinicians to help have conversations about like end of life, basically about like one's healthcare. And so right now I've been like working as a research coordinator, and it's been really great because I've had the opportunity to independently lead a lot of different studies, like using ICES data. So like from beginning all the way to like the publication and like dissemination of findings. Like and it's been it's like I said, it's not just palliative care. It's in a variety. It's using a variety of different data sets on different topics. So, for example, I've helped lead some of a lot of the critical care research. So, like I said, looking at life support, ECMO, um, uh, and other studies pertaining to like home care, dementia, and then recently like long-term care and looking at how long it takes for patients to like receive long-term care, and immigrant health. So it's a variety of different topics, and I really really enjoy it because it's really helping me understand like what I want to do in my future, whether that's a PhD and when what exactly I would study. So it's been really great.
Throwing it back to your segue there, I want to talk about one of your most recent publications where it was looking at differences amongst recent immigrants and longstanding residents waiting for long-term care. I want you to talk about that because that I think was a very cool paper, and I got some questions about that one.
Oh yeah. Okay. So like so this study was just published in JAMDA, and I'm actually like it's a very interesting study to do, and because like these are like ongoing problems that haven't really been addressed,
Mm-hmm.
and it's surprising that like not many people have already looked at this topic. But in this study, basically, we describe the differences among recent immigrants and longstanding residents in terms of how long they wait to receive long-term care services. So how long does it take for them to get admitted to a long-term care home? And what we found is that basically recent immigrants, they tend to be worse off when it comes to when it comes to the time to placement. And so we found that they have lower number of comorbidities, but like worse functional health status than their long-standing residents. And so what we measured was their time from the waitlist entry to long-term care home admission. So just to give you some more context, like when you apply to long-term care, you are asked to fill out an application, and on that application, you list, I think, 5 homes. 5 homes you list in priority in terms of like, which one do you want first,
Mm-hmm.
and then you're matched according to your list,
Mm-hmm.
but also like your overall health based on a few different scales, like your functional health. So they look at your overall profile and then your rankings, and then they match you accordingly. And so the problem right now is that a lot of these homes, like they're over capacity to begin with. So like that's why there's a list. Like you're not going to get the first home all the time. And another problem is that if you need long-term care services, like you cannot wait. Like you cannot wait for these services. Like
Yeah.
if you need long-term care, that means you need care immediately, like around the clock support. Um, and so that's a problem already to begin with. And then on top of that, if you're a recent immigrant, things are even worse for you because generally the home that you apply to, the first home that you choose, is usually a home that will cater towards your specific cultural and ethnic needs. So like, for example, if you speak Arabic, you want a home that, that has people working there who speak Arabic, right?
Yeah.
Or like,
Yeah.
certain services in place that cater towards your cultural, ethnic, or religious needs, right? And so there's only about like 50 homes
Mm.
that cater to, that actually like considered like cultural and ethnic specific homes in Ontario out of like 600.
Wow.
So there's a problem right there, and like each of these homes, like one home might specifically cater to a particular, ethnicity. So it's not like, oh yeah, it's cultural ethnic specific. It means like, okay, like anyone from any,
Yeah.
any immigrant can go to this home. No,
Yeah.
it's like sometimes cater specifically to a specific group of people. So what we found is that these patients are waiting a lot longer for care. They're on the wait list for a lot longer than longstanding residents. And this is particularly the reason for this. There's a lot of reasons, first of all, based on like previous literature. But what we found in particular is that a lot of these homes, a lot of the ethnic and cultural specific homes, they're concentrated in the GTA area, and a lot of the recent immigrants are in that area. And so one of the reasons is these immigrants are in lower income neighborhoods. So naturally, when you say lower income neighborhoods, you think of like poor housing options. You think of like poor access to like simple things like groceries.
Yeah.
If there might not be in walking distance. Maybe people don't even have like a car to like get there,
Mm-hmm.
or like access to healthcare. Let's say you want to go to like a specialist, but like they're in like a city like 2 hours away. How am I gonna get there? If I don't have the money to get there. So that adds to the issues. But what we found is that the recent immigrants, they're more often applying to these ethnic and cultural specific homes. And that is playing a huge role in how long they wait because they're already over capacity, they're already limited. And so naturally they're going to wait longer
Yeah, and there's so much
to receive
fewer than
services.
them than say the other 550 that are available to the average Canadian who's fine with the English or the French and
Exactly. So it's a variety of problems. And like, to be honest, like this study doesn't even like cover it. Like it covers literally just one problem. Like I can't even expand further on that because there's
yeah.
like way too many issues.
Do you know where you want to go next with this, or is that sort of what you're figuring out now as you figure out if you want to do a PhD or what you want to look at? Do you know what you kind of want to where you want to take it next?
Yeah, no, that's a great question because obviously, like I'm really interested in this topic,
Mhm.
and I was actually thinking about like taking it further with the PhD, and I'm in the midst of applying to several PhD programs, and so what I'm proposing for my PhD, well, right now I might change in the future, but is I want to look at the healthcare experience for those who have a severe infection of COVID-19, and like how does that experience differ by immigrant status? And
Interesting.
yeah, because right now, based on like what I've been reading, is that and maybe you have read this too. Basically, if like people who are visible minorities or immigrants, they tend to be, first of all, they tend to have a higher rate of infections despite representing a
Hmm.
much lower proportion of the population. And secondly, when they do have an infection, it's more often severe than not. And so that leads to worse health outcomes like mortality, higher rates of mortality, higher rates of complications. Um, and again, there's a plethora of factors that play a role in that, right? Like in terms of simple things like working from home, having the ability to work from
Mhm.
home. A lot of a lot of the jobs that immigrants have, they cannot do from home. Like they have to still go in to work.
Yeah.
Um, so that's just one aspect of that. So I really want to look into that further because there seems to be a lot of racial and ethnic disparities that are highlighted through COVID. And what's interesting about COVID is that it's not just about COVID, it's actually highlighting pre-existing problems too. COVID has kind of highlighted
Yeah.
problems that already exist.
Yeah.
Yeah.
That's especially
So that's
especially in healthcare. Oh, obviously, but I mean, even the problem of us already having hospitals running at 100% capacity, that was already a problem before. And now we have to deal with this huge influx of I think that's what I'm curious to see, what changes might come after COVID. Like, are we going to learn? Hopefully.
Yeah.
I hope so. Are we going to learn from all these things?
Yeah, no, it's really interesting because it's brought about existing problems and new problems too. And some of these things I haven't even thought about before. So
Yeah.
it's allowing people to kind of think differently in terms of how we perceive our healthcare, and like highlighting some of these disparities that exist. Like even me, as an immigrant, I didn't know some of these problems existed until now.
Yeah. Wow. Okay. Well, that's fantastic and super. I am glad you spoke about that, because I had seen in a paper at the start of COVID where they were sort of talking about it highlighting those racial disparities and exactly what you said about the jobs, but no one's really speaking about that. And it's nice that there are people like you who are trying to sort of dig deeper and shine a light on
it. I don't know. Like a lot of it's contingent upon the data again. Like it's like we don't have the data right now, right? Mm-hmm. It's lagging behind, and but like there's been a lot of initiatives in place, like not just in Canada, but like globally, to kind of provide better access to data pertaining to COVID. So so like when someone gets tested, they try to collect some of this data on like race-based data, ethnicity, because right now in Canada at least, that data is lacking. It's very limited, and even for the study that we just did, like looking at immigrants, it's still limited. Like there's a reason that I'm saying recent immigrants versus long-standing residents. There's a reason I'm not saying non-immigrants, because the data that we used, it only captures immigrants from 1985 and onwards. So anyone who came to Canada before 1985 and is an immigrant are considered long-standing residents in my study. And so like there's like limitations like that someone wouldn't know about unless they actually worked with the data. And so like it could definitely be a lot better, and there's a lot of initiatives going on right now to improve access to like more rich and comprehensive data so that we can do better studies that are more informative.
Okay, so note to self, I have to spend more time having maybe the uncomfortable end of life conversations with people in my circle, that's actually very uncomfortable to think about doing. But that's sort of that's something I'm taking away from you, is that better prepared than sorry, or better. Oof. Okay. Wow. So much to think about. Okay. Okay, but I appreciate you so much coming on and talking about all this. That was very interesting, to say the least. And I'm so glad that you brought all this up. And I just feel like there's so many things that I got to think about now, and some uncomfortable conversations I have to get better at having.
Yeah, no, and even for me, like I still feel like I don't know enough about end of life. Even if I'm doing the research in the area, I still feel like there's so much more to learn, and even palliative care. And I'm worried about defining it properly, and because it's a lot more than what it seems like. Mm-hmm. So.
Well, we'll have to have you on once you're doing your PhD, so that we can get a continuation. Take 2.
We'll see.
Best of luck, though. Yeah. I'm sure you'll be fine.
Yeah, we'll see. We'll see.
Are your apps already in, or are you still sending them out?
I'm in the middle of submitting the application, so we'll see. Maybe I'll be in Ottawa. Who knows?
Yes, join CSAB.
Yeah.
We'll turn a full Ottawan. I don't know what we call ourselves here. We'll turn you into a full-fledged Ottawan. Bye, Toronto.
Toronto's still in my heart, so.
Okay, awesome. Well, thank you so much for coming on. This was fantastic.
Yeah.
And I really
thanks a lot. I really appreciate you having me on. Thanks a lot, Gabby.
Thanks for tuning in this week. If you want to stay updated with Danial Qureshi's research, follow him at DQURESHI_. That's at Qureshi on Twitter to see what he's doing with palliative care research at Bruyere Hospital in Ottawa. While you're at it, follow at Behind the Numbers with no E in numbers on Twitter and Instagram. And please rate, review, follow, subscribe, comment on everything Behind the Numbers. Please help us get our name out there. Thank you so much for listening, and see you next Monday.